The most important advice, I think, to give patients with any kind of chronic respiratory disorders really is the fact that they are at the highest risk for some of the most serious complications from this infection, including life threatening ones such as respiratory failure and death. And so I think the best advice would be to really stay home. I think, which is what all the major, public health authorities have recommended. And I think it's good advice really for everybody, but especially the most vulnerable patients who are these high risk folks to avoid potential contact with this virus. Also, minimize contact with anyone who is sick, and also frequent hand washing, avoiding touching your face and hands, also disinfecting a lot of commonly touched areas around the house. I think these are all extremely valuable pieces of information and advice that we want to, in order to protect our patients who have these chronic respiratory diseases. This is something where, for folks like myself who do practice and take care of a lot of patients with interstitial lung diseases, which is, as you know, a chronic respiratory disease, it requires a lot of follow-up and maintenance and checkups. Usually every 3 to 6 months, patients should be monitored. And this is something that, with the current COVID-19 pandemic, it's become very difficult to be able to see the patients as frequently as we would normally like. And so what we've now moved to, which I think a lot of people around the world are doing, is moving into telehealth. We're using telephone visits and even video visits to be able to talk to and see our patients to make sure that they're doing okay. And that's something that as this past week, I've done 2 afternoon sessions and called 9 patients each session to talk about their ILD, make sure that from a respiratory symptom standpoint that they're doing okay. How are they tolerating their medications? And then, instead of a physical exam, which we normally do in the clinic, instead of breathing tests, which we normally have and review, we basically just jump right into the assessment and plan. And based on their symptoms, how they're doing, this is the plan that we're going to come up with, and then try to organize a good follow-up visit after the pandemic situation resolves, so that we can see them back in the clinic and get some breathing tests and maybe a CT scan if we need to. About 2 weeks ago, we basically here stopped doing any breathing tests because of the potential that somebody may have this infection and could contaminate the PFT machine and the equipment. This is actually, there is evidence, that was a study recently published in the New England Journal that basically showed that the virus can be viable not only in the air for, I think, up to 6 or 8 hours, but even on various surfaces like cardboard up to 24 hours and other hard surfaces, including plastics, for a couple of days. So to me, I think if you continue doing PFTs on these patients, and if not only are they at increased risk for contracting it, if they're exposed to someone but having a problem with it, PFTs would also have a high risk of getting contaminated. And then the patient follow-up afterward, if the machine is not disinfected properly, then could also expose them. So I'm pretty sure that most respiratory clinics have stopped performing routine PFTs at this point. We would only recommend PFTs now in this pandemic for only the most urgent cases. And for example, a patient who has lung cancer who needs to have surgery for curative intent, and the surgeon requires a PFT to make sure that their lungs can handle that surgery. I think these would be the only kind of exceptions to the rule, which right now would be really no PFTs. Even any elective CT scans, we've stopped doing as well, just in the interest of protecting our most vulnerable high-risk patients from potentially contracting the virus. So, I mean, I think with any of these chronic lung diseases, and since I'm an interstitial lung disease doc, I can only imagine it would be similar for asthma treatments and for COPD, that we have typically patients on chronic treatments, whether it be inhalers or specific treatments. But specifically for interstitial lung disease, typically we have patients on antifibrotics, which, as we all know, have a high potential for side effects. And especially if they're starting out on antifibrotic like OFEV, that we would check liver function tests at baseline, at 6 weeks and 12 weeks. And with pirfenidone, Esbriet, we would check it at least monthly baseline and monthly for 6 months, and then every 3 months thereafter. So it's become a little bit more difficult to monitor patients while they're on therapy because of the inability, perhaps, of getting lab checks, because maybe those laboratories are not open, or may not be safe even to send a patient to a waiting area where there's other sick people waiting for blood tests too. The other thing is that I have some patients who, with different types of ILDs, who may be on steroids or on immunosuppressive drugs. Again, these oftentimes require close monitoring, and also in terms of lab checks. So I've tried to do my best in terms of help patients get these blood checks done at home. And so far, I'm still in the process of ironing out some of the kinks in terms of having a home health nurse come out to perform these lab draws. But in my mind, that would be an ideal situation to minimize their potential exposure to the virus, or somebody who has it, rather than sending them to a lab where they might have a much higher risk, because not only other patients in the waiting area, but perhaps even other healthcare providers who might have who may be asymptomatic or have mild symptoms of the virus and still going to work. I think this is this is something that all healthcare providers, I think, all over the world who are taking care of these COVID-19 patients are struggling with, in the sense of we have not only our duty to help other people who are ill and who are sick, but it's also it's our passion to do this, to take care of other people. This is what we love to do, what we train to do, and we want to help as many people as we can. But when you are talking about a new uh, infectious disease that is contagious, and thankfully most people do okay with it if they get it, but there is pretty significant number of patients that, if you do get it, no matter how healthy or not you are, you have a pretty high risk that that you could have serious problems with it and maybe even die. That's a concern that we all have when we take care of these patients, and whether or not only for ourselves are we going to contract it, but maybe even more so, are we going to spread it to our family members at home? And this is something that um, all of us, I think, who take care of these patients are very mindful about the importance of being as safe and donning and doffing, as you probably have heard on the news, those terms of the personal protective equipment, as safely as possible, making sure that we're as protected as possible. But there's a significant concern that the PPE shortages around are going to not only impair our ability to take care of the patients the best as we can, but also put us at risk for contracting the virus and spreading to others. So it's a balance that I think everybody is struggling with, and I think we all want to help our patients, but we have to also we need to do it as safely as we can.